Hello, my name is Dr. Francis Ferre. I'm the director of the Inflammatory Bowel Disease Center at Boston Medical Center and a professor of medicine at the Boston University School of Medicine. Thank you for joining us today for No Doesn't Necessarily Mean No, Strategies for Successful Prior Authorization Appeals for Patients with Inflammatory Bowel Disease. This is the third of a three-part series designed to provide you with some best practice strategies and actions you can take when your prior authorization is denied, and to discuss strategies for the appeals process with the mindset that no doesn't necessarily mean no. Part 1 of the series highlighted the workflow strategies to improve your prior authorization success. And in Part 2, we addressed best practices in the electronic health record documentation. Knowing that the activities will generate questions, we've created a platform so you can submit your questions to us by completing the adjacent form. Responses to the questions will be posted on the Gastroenterology Digital Hub at cmeoutfitters.com as part of a library of toolkits, templates, tracking spreadsheets, appeal templates, and patient education videos that can be used in practice, and resources to share for use with your team that's involved with the prior authorization process. And for those of you who complete the full series, CME Outfitters will award a Certificate of Excellence in Prior Authorization. Our panel today reflects the diversity of the team that contributes to the successful prior authorization appeal. With me are my colleagues, Michelle Rubin from the University of Chicago and Tony Zahorian from Boston Medical Center. Michelle is an advanced practice nurse and Associate Director of the Inflammatory Bowel Disease Center and Director of Advanced Practice Nursing at the University of Chicago. Welcome, Michelle.
Thank you.
Dr. Tony Zahorian is a clinical pharmacy specialist at the Center for Digestive Disorders at Boston Medical Center and my colleague in the gastroenterology department there. Welcome to the program, Tony.
Thank you.
In this third module, we're going to be focusing on the appeals process when a prior authorization is denied. Our learning objective is to develop a process for an organized and clinically supported appeal for prior authorizations that are inappropriately declined. In our first module, as you can see on this slide, we describe some of the best practice tips for successful prior authorization. You need to identify the top 5 insurers in your practice, know if they use an electronic prior authorization form, know their phone, email, and fax numbers, what are their processes and criteria, and be sure clearly to use the right forms. You need to monitor measures. You need to know the information that they typically require in their prior authorization. Designate a payer point of contact to own the process. Develop a tracking process to ensure requests don't get lost. When submitting several prior authorizations, you can lose track of an authorization that was submitted several days ago and you've yet to hear from the insurance company. And clearly track both wins and losses. In Module 2, we discuss the important clinical elements to routinely document in the patient's electronic medical record to ensure that if you need to get a prior authorization, all the information needed is already contained in the record. So for example, on this slide, create a template whenever possible for the electronic medical record that includes the year of diagnosis, detailed disease course, include their colonoscopy, imaging results, the type of disease, ulcerative colitis versus Crohn's disease. Is it pancolonic ulcerative colitis? Is it ileocolonic Crohn's disease? Do they have perianal involvement? Include in the template what their inflammatory markers are, their CRP, their fecal calprotectin. Many insurers require that we document hepatitis B immunization and that they've been tested for TB and they're not exposed. Include in the electronic record how often they've had disease flares. We really want to paint a picture of how this particular patient is suffering with their disease. And all prior medication and failures should be in one section of the note. At the end of your note, summarize the clinical need for a new medication while you're moving on to a new class of drugs or a different agent, and include reasoning if you're requesting an agent that's not their preferred agent. So despite even your best efforts documenting what we reviewed in Module 1 or 2, denials still happen in our patients with inflammatory bowel disease. Michelle, is this specific to IBD or is it happening in other fields?
No, it's happening in other fields as well. And this slide here demonstrates, it was a doctor-patient rights project. And this showed a denial for chronic disease medication areas. And as you can see here, 1 in 4 were denied coverage. So 55% of denials were for medication, 29% of individual denied coverage reported a deterioration in their health as a result.
So we can see clearly this is not a problem just for patients with inflammatory bowel disease.
Absolutely not. So as you can see, Frank, it's not just in IBD, but let's take a look at how it is in the inflammatory bowel disease group. So 49% of gastroenterologists reported an experience with a patient who was stable on maintenance therapy, but had to stop due to a denial. You know, that can be devastating on the health for the patient. 62% indicated that reimbursement barriers have resulted in modification of biologic chosen. And 17% stated that this occurred frequently. So as you can see, this is really, we have to be on top of these, getting these reimbursements and getting our prior auths to the best they can be as far as the documentation needed to make sure that denials do not occur.
Yeah, I would reiterate that. This is something that we do see in our practice, and it clearly disrupts patient care and in many situations can lead to an exacerbation of their disease. Tony, so when you do get a denial letter, where do you start? How do you go about supporting the IBD practice in appealing the denial?
I find that a good first place to start is just finding out why the prior authorization was denied in the first place. Sometimes this is something simple. Some information was missing. Maybe they just want more information about prior medications or hepatitis B testing. This can just be added and sent back in. Not all payers will require an appeal after an initial denial. So occasionally you'll get multiple chances to submit your prior authorization before you reach the appeal stage and before you need to do a peer-to-peer. Occasionally denials are a bit more severe. Maybe they decided that this was not medically necessary or did not meet the clinical rationale based on their criteria. At this point, you may need to submit additional literature or actually do the peer-to-peer to support why you've made this clinical choice. Other reasons for denial include simply that you've selected the wrong form. This can be easily avoided by using electronic medical prior authorization platforms such as CoverMyMeds. This would allow you to select the patient's insurance and then actually provides you with the correct form for that medication so that you do not have to fill out a form and then redo all the work that you've already completed.
Thank you, Tony. So we've received a denial. Tony pointed out some of the ways to appeal the denial. I guess in your practice, Michelle, do you always appeal?
Yes, we always appeal. You have to be the patient advocate here, and it's very important that you do work toward getting an approval for them. So first of all, the denial letter is often going to offer options of how to submit an appeal. So really look at the denial letter and look at what they are requiring. Ask for a peer-to-peer reviewer, and I would say particularly in a situation where their requirements are sort of based on the step-up approach, and they need to talk to the provider to understand, no, this patient may have moderate to severe disease, and we need to start out with a biologic in the beginning and looking at their risk factors. Submit the letter of medical necessity, clinical trials, abstracts, office visit notes, utilize supporting literature and referring evidence, particularly like our AGA guidelines and the clinical pathway that we talked about in the previous module. Be assertive and be persistent. You are the patient's advocate, and we want to get these drugs approved for these patients. Exhaust every level of appeal available, and looking there on the right side is moving from peer-to-peer, your first appeal, second appeal, sometimes an external appeal is needed, and if nothing there seems to work, then appeal to the State Department of Insurance. And often you will get the approval you need.
Thank you, Michelle. So now let's talk about the elements that go into a successful appeal. Tony, what should clinicians be thinking about when they sit down to craft an appeal?
As Michelle mentioned, I think this is really your opportunity to advocate for the patient. And I do think it is important to include in your letter all of the objective information that led to your plan to choose this particular medication. But what makes an appeal letter unique is this is your opportunity to provide more of a narrative on the patient's condition. So not only that objective information, but also subjective information about how the patient is doing, and sort of weave that into a story about the patient's condition, including their lab values, their previous medication trials, and their current symptoms. You should also make sure to reference these choices. So make sure you're including literature and a reasoning behind what you're doing to support your argument. At the end of the letter, I would recommend supporting your concerns about inadequate treatment. So potential hospitalizations for your patient, emergency room visits, or even surgery, and what that could mean for your patient's quality of life, and also increased healthcare costs. When writing an appeal letter, it is important to offer to provide any additional information that might be required at the end of the letter. Make sure that you write this letter on an official letterhead and it's signed by the provider with the correct contact information in case they do need to reach you for additional information. And probably most importantly is follow instructions. Each payer will have different instructions as far as how their denial letters should be written, and you want to make sure to follow those so that you do not have additional problems.
Michelle, are there resources and template for appeal letters just like they are for the initial submissions to the insurance company?
Yes, there are appeal templates, and once again, it's very important to use those. It just makes it more efficient and simplified for you when submitting them. But there are ones that are for Crohn's disease, for ulcerative colitis, and there's letters that are for drugs that may be for both. And as we said, this can expedite the process. The Crohn's and Colitis Foundation has excellent templates that you can get off the website.
Michelle, where do you go to find other resources to support your appeal letter?
Well, you can ask colleagues and experts in the field of IBD to help you support that. The Crohn's and Colitis Foundation, as you see, there is a link here. They have multiple appeal letters there that you can use and customize for your patients. There also is the online evidence summaries, the uptodate.com, where it has your most current information on the treatment pathways, etc. Here you also, we talked about earlier in our previous module about the AGA Crohn's disease clinical care pathway and the AGA ulcerative colitis clinical care pathway that you can use as evidence to support your use of the biologics. And in addition, you can search IBD journal websites. And Tony, can you tell us what you do when you search for IBD journals?
So I think the important thing to note about this is that it can seem overwhelming because it can be certainly time consuming. Yeah. And so what I find to be really useful is to do the literature search and save the work that I've previously done as a PDF on my computer so that when I have future patients who might require a similar treatment with the same literature, that I have that saved and I don't have to do the research from scratch. This is helpful, but you also want to make sure that you're updating that literature when new things become available.
Yes, that's right.
Tony, in our first module, we heard from the gastroenterologist that I had surveyed a lot about their peer-to-peer review experience. What exactly are they?
A peer-to-peer is an opportunity to discuss the denial that you've received and present new clinical information that could potentially reverse this denial. It is important that although you might be frustrated at this point in the process, not to be combative with the reviewer. It's important to start off by thanking them for their time to review the case. Also take into account the reviewer's perspective. They must apply the payer's coverage guidelines and use their clinical judgment to render the appropriate decision. So hopefully you're on the same page, but they do have multiple things to consider. I would also recommend requesting a same specialty reviewer. Michelle mentioned this earlier. If you find a reviewer that you've worked with before that has worked out well, you could also save the name of that person and request them for future reviews.
So Michelle, Tony just reviewed with us some of her tricks for embarking on a peer-to-peer review. What do you do in your clinical practice to increase your odds of obtaining the appropriate medicine for your patient?
Well, I definitely prepare ahead of time. I review the denial letter and make sure that we are addressing the reasons for the denial. So definitely you need to have the patient's chart in front of you, re-examine it for any concerns that were noted in the denial letter so that they get covered. Schedule the peer-to-peer at a time when you are readily available. Provide a phone number where you can be reached. This is very important so that you coordinate the timing that is appropriate for both. Confirm that the payer received the correct and complete documentation with the initial submission. We often know that faxes get lost in this underground world of faxes that never get viewed, or someone else takes the faxes off the machine. So you definitely want to make sure that they do have the right and correct documentation. Ask if the reviewer has had a chance to review your documentation. That is very important as well. In addition, explain your case. Be succinct. Provide facts from the clinic notes. Be sure that you are working off the clinic notes so that you're all on the same page. And be sure that you are painting a picture of that patient's clinical focus. Support your case if asked to submit additional information. Be timely. Don't wait a couple weeks. Get it out to them as soon as you can. Otherwise, this just further delays the approval. Document the outcomes. Get an authorization number if provided. Verify the peer reviewer's name and credentials. If successful, ask for the same reviewer when for future denials. Understand the next step. Often it's very important to reiterate back what the understanding is of what the next steps are needed.
Tony, we covered patient assistance programs in Module 1, but I think a review would be valuable for clinicians in case the appeal is denied. What's available for these patients in which the appeal is denied and they cannot get a particular medication through their insurance company?
Great question, Frank. There are many foundations that do provide assistance to our IBD patients who have not been approved for their medications or potentially who don't have insurance at the time that they need treatment. Unfortunately, many of the sites listed here and the foundation's chronic disease state funds specifically oftentimes do run out of money because this is a very common disease state and these funds are utilized up very quickly. For those patients who still need assistance, there are patient assistant programs. However, the eligibility criteria do vary, and we again discussed this in Module 1. So it's important to review those criteria and make sure that your patient does qualify for this patient assistance program. The programs listed here on this slide vary based on the biologic that you are trying to select. So you simply just go to the website and register the patient.
Michelle, we get very frustrated as providers by this process, but clearly this is nothing compared to what our sick patients are going through. As we initiate this process, how do you, as a frontline clinician seeing these patients every day, manage their expectations while we're waiting to hear from the insurance company?
Well, first of all, I really keep in contact with these patients and, open discussions between them that yes, there is an appeal process. It may take a little bit of time, but we are going to try and expedite the information they want, and we're going to try and expedite this process for you so that we can get you on the appropriate medications. And so discussing possible timelines is very important because there's nothing like leaving a patient out there hanging. They know they need this medication and they're just getting sicker in the meantime. So you kind of want to give them some timelines as to what the expectations can be. And the electronic prior authorization process and all of that does help expedite that sometimes. But it's very key that we do get all the appropriate information from the patient and the clinicians in this process. So we kind of tell them what the process is and why it takes a little time. And then always discuss backup plans and availability of patient assistance. If we get another denial, what can we do in the meantime here? And then let them know about a patient assistant programs, just as Tony had talked about in the last slide or two. And medication education. This is another great time to educate them about the medications and the biologics to sort of keep them engaged and involved, that we have every plan that we are going to move forward with this and we want to maintain a positive attitude with this patient. We will get this approved.
Thank you, Michelle. Clearly our patients are suffering, and anything we can do to move the process in a quicker way, it would be appreciated by all. In fact, one of the ways that GI societies are dealing with this is by going to Washington. So maybe Tony can update us on where legislation is in Washington to be able to respect our patients' rights to get the right medicines?
Sure. So the Restoring Patients' Voice Act would provide patients and providers with a clear, equitable, and transparent appeals process when they are subject to the step-up therapy protocol or criteria. This act is supported, or this proposed legislation is supported by the AGA, the Crohn's and Colitis Foundation, and the ACG. So you as a provider and your state GI or local medical societies can work with state legislature to improve access for your patients and also support this legislation.
I want to reinforce what Tony just said. A famous politician said that all politics is local. In our state of Massachusetts, we are actually working with the state legislature to try to come up with a more equitable way for patients to avoid step edits to receive appropriate medicine. So I would encourage all of the listeners to reach out to their local GI society and see whether you can engage them in moving forward with local legislation in your own state. Often this is a way to get the job done while waiting for Washington to come up with a plan that will affect the entire country. Thanks, Michelle and Tony. This has been a great discussion today. As we wrap up, let's leave the audience with some takeaways and action items to improve their PA appeals process. Michelle, can you start off?
Yes. Well, denials happen. Even though I know they're very frustrating for us to go through, they do happen. But the key is that we understand why the denial is occurring, and then begin to build the case to get the approval that is needed. Successful appeal letters include the detailed information about the disease course, the severity, medications that are tried and failed, and procedure results that confirm the patient's extent of disease as well as the severity. And support and supplement the patient data with clinical trials that are evidence-based on literature and journal articles. That is key to be sure that you add that to the denial letter.
In addition, if a peer-to-peer is required, I think you should approach this as an opportunity to present a prepared case for the medical need for your patient for this particular medication. If the medication is still denied, then take the opportunity to utilize the patient assistance programs that are available, and keep open communication with the patient during this process. Michelle mentioned this earlier in the program, and I really think that's key because prior authorizations do not happen overnight, and the patient can often be left wondering what stage of the process are we in and how long can they expect this to take. And finally, ultimately, this is all about patient care, so make sure you do your best to get through the process and don't give up.
We hope that we've given you the tools necessary to advocate for the patient and navigate the appeals process. We do, however, recognize that payers need to control healthcare costs. We as providers need to be a partner in this process and not an adversary. I'd like to thank Michelle and Tony for this very practical discussion and for sharing their insights, experience, and strategies for maneuvering the prior authorization appeals process. Please visit the Gastroenterology Digital Hub at cmeoutfitters.com, where you will find all 3 modules, as well as template letters, checklists, and spreadsheets to help you build or improve your process. You'll also find a video for patients explaining what they can expect from the process that you and your patient may find helpful. And remember, for those who complete the full series, CME Outfitters will award a Certificate of Excellence in Prior Authorization. We sincerely hope that we were able to provide you with the tools to improve your processes, allowing more time for patient education, meeting patients' medical needs, and improving the outcomes of our patients with inflammatory bowel disease.